Dr. Wilson graduated from University of Minnesota School of Medicine. After family practice residencies in West Virginia, he spent the first 14 years of his career as a rural family physician in Minnesota. Since 1991, he moved his practice to Asheville, North Carolina, and has focused on environmental and nutritional medicine, with interests in heavy metal toxicology and neural therapy and autism. He has served as past president of the American Academy of Environmental Medicine and the Great Lakes College of Clinical Medicine, now called the International College of Integrative Medicine, and is currently the director of continuing medical education for the American Academy of Environmental Medicine. He is the owner of the Great Smokies Medical Center in Asheville, North Carolina. I wasn't aware of this impressive list of credentials, John, but having supper with you a few times, I know you're a straight shooter and you got a lot to offer, so please welcome Dr. John Wilson.
Thank you. Well, I will begin by mentioning that I have no financial interest with anything or anybody, I'm just here to tell you what I know and what I've learned about chelation therapy. And I've been involved with, as you can see, just a few things, the organizations I've been with, and have been involved in clinical metal toxicology work really since 1988, when I first started doing chelation therapy and learning about the different agents and how you can get mercury and other toxic metals out of the body. Can I just see a show of hands? How many in here are dentists? And how many of the hands that are up, how many of you are working with a medical doctor in conjunction as well? So it looks like a minority of people here actually have an MD to work with. And I'm going to encourage you all to try to figure out how you can team up with a medical doctor. I'm going to be talking to you about mercury detoxification and as it relates to dentistry, but I'm not, according to Boyd Haley this morning, I found out I'm not a scientist anymore, and I would have said that before he did in any case, because I think clinicians are ultimately pragmatists, and we have experience with people in a clinical setting, and we try to figure out what makes people better, and if you start seeing results that are consistent, because ultimately science, I think we are sort of scientists, because science is ultimately observation and reproducibility when you get right down to it. And so we are scientists with an N=1 population number we're dealing with. So what I'm going to be talking to you about is mercury, and as it relates to detoxification, and a sort of blurring the lines between what you can do as a dentist and what you can do as a physician. And of course, physicians have more license to go after mercury burden in other parts of the body other than in the teeth, and we don't really have any license to go there. So I think we really, on both sides of the aisle, we really need to be working together for the patient's best interest. So some of the things I'm going to be talking about are going to be protocols for detoxifying mercury that we have up to the current state of art. And before I begin, I want to say that I really think we don't have a very good state of the art. Now, I'm hoping that when Boyd Haley comes out with his new magic chelating formula, that we're going to really see the whole system turn. But in my opinion, at least, that I think we are plucking away at a slow level of the mercury, and we're not getting it at the mother lode with the agents that we have, which is the best that I know we have to date, and that's what I'm going to be talking to you about. But I want you to have an understanding that I really know that the mother lode is still there, and we're still trying to get it out. And I'll be elaborating on that further. I don't have to talk to you about mercury, not anybody in this group at least, but there are some people who maybe haven't heard this before. Just to refresh everybody's memory, that mercury occurs in nature in 3 different forms. There's the elemental or the atmospheric or a vapor form of mercury. There's inorganic mercury, and then there's organic mercury, where mercury is attached to either ethyl or methyl groups, and it is the most toxic of the forms of mercury, and it is the one that is probably the greatest concern that we have. But we have concern about any form of mercury in the body. Elemental mercury is what comes off the teeth, and we've all seen the nice pictures in the smoking teeth poison gas videos, and we know that the vapor comes off, and it can be inhaled. When it gets into the bloodstream, and anytime it combines with any of the tissues of the body, it's going to be searching for anions, particularly chloride, and is going to be binding up with that, because elemental mercury is not going to be staying elemental once it gets into the body. It becomes methylated only through bacterial action, so it's not going to methylate otherwise, according to the wise words of Dr. Haley in my most recent conversations with him. So that means it's going to be swallowed, and you're going to get into the gut bacteria are going to be methylating it. And of course, we get ethyl mercury from thimerosal. Dr. Haley spoke at length about that. But understanding the different forms of mercury helps to understand some of the aspects about what we're going to do to try to get it out. Mercury distributes in the body according to sulfhydryl groups. The study that was quoted this morning in 1999 in the American Journal of Cardiology showing that patients who died from idiopathic dilated cardiomyopathy had 22,000 times more mercury in their heart muscle than patients who didn't have that disease. It just shows that the heart is extremely metabolically active tissue. Our metabolism is run through specialized proteins called enzymes. An enzyme's job in the body is to grab a hold of chemicals, bring them together so they can interact. And the active binding site of most all our enzymes in our body are indeed sulfhydryl groups. So the most metabolically active tissues are the ones that are going to have the highest concentrations of enzymes, and that's where mercury is going to be. If you're trying to assess exposure, we can look at hair and hair analysis. A recent exposure, we will see it in the hair. The hair is out there in the environment. The hair is rich in sulfur groups and will trap mercury in the environment. The blood mercury, when we're looking at red blood cell mercury, that's going to be telling us about what mercury has been picked up in the life of that red cell, and the average life of a red cell is 120 days in the body. But I see it repeatedly where patients come to my practice and they've been to other doctors, and the doctor does a red blood cell mineral or mercury test or a whole blood mercury level, and they don't find it, and they say, aha, see, there's not a problem. The half-life of mercury in the blood is only about 3.5 days. It's quickly partitioned away from the blood and into other organs in the body, and so you're not going to find it if you're looking there, trying to find a body burden. An unprovoked urine. The other test that they'll do typically is when they'll see a doctor, even if they go to Mayo, the doctors at Mayo will say, well, let's do a 24-hour urine collection. So they collect 24 hours worth of urine, and lo and behold, they don't find any. So therefore they conclude there's not a body burden of mercury. But it fails to recognize the biology of mercury, that it's not going to be turned loose. It's going to be stored away in other compartments in the body. A serum beta-2 microglobulin is a test that very few physicians do use, and it is a marker not only of recent exposure, but also of a body burden. It's a protein released by the kidney cells if the cells are being damaged by toxic metals, and there is some literature out there to support that contention. If you do a Google search on serum beta-2 microglobulin, you'll probably find that it's a marker for a certain kind of plasma cell cytomas. But it actually you will also find some citations that identify its link with cadmium and adverse effects of cadmium in the kidney. But I think it also is a marker for other toxic metals. I've been using this marker in my practice for probably about the last 12, 13 years. And it's interesting, just as in my patient population, that about 12, 13 years ago, I might see 1 or 2 out of 10 patients who had elevated serum beta-2 microglobulins. And now I see 8 to 9 patients out of 10 that are having elevated beta-2 microglobulins. And I was musing over this in December when I looked back over my practice in November, and I had done the test on 20 different patients, and all 20 were high. And so I think that it represents that we're seeing a higher degree of toxicity in patients today in comparison to what we saw years ago. Well, there's other things that can cause the beta-2 to go up, of course, but you see it rise and fall with toxic metal exposure, and I'll comment a bit further about that as well. When we're looking at body burden, which is what we're really interested in, we don't really have a great dipstick we can stick in the body and say, well, you're 3/4 full of mercury now, and now you're half full as we go through the process of treating. The best test we have, I think, is the provoked urine test. And a provoked urine test is where you take a chelating agent that will bind preferentially to mercury, and you have the patient collect urine for a period of time afterwards, and I'll describe that test in greater detail. And then you measure the urine afterwards. And as you go through the process of chelating somebody, you should see, theoretically, the levels come down. It's not linear at all. and which I'll comment on a few cases about that. But I like to liken that test unto a blind man standing underneath an apple tree. And he shakes the tree and then walks around on the ground and picks up the apples he finds. And then he comes back another day and he shakes the tree some more and he picks up more apples. And as he picks up fewer and fewer apples, when he gets to the point there are fewer apples, he concludes, there's not many apples left in the tree. Well, we are the blind man, and the apples are the mercury. And it depends on what time of the year you're shaking that tree, And there's a lot of factors that determine that. And so an absent production of urine of the provocation test does not mean the person does not have a significant body burden. And you heard today about, we talked about hair analysis earlier. I think that a hair analysis is a bit of a deceptive test, because the most toxic, mercury toxic patients that I've seen in my practice have the lowest level of mercury in the hair, and that was confirmed with that Holmes and Haley study that was mentioned this morning with the autistic children, but I've seen it with adults repeatedly as well. If a person has a known mercury exposure, and they're not eating tuna fish every day, of course they're going to be astronomically high levels of mercury in the hair from that, but if they have 6 or 8 fillings in the mouth and you find some mercury in the hair, that's a bit of a comforting sign to me, because it means they do have some biology that allows them to excrete the mercury. And of course the urinary porphyrins, which Dr. Haley mentioned this morning as well, which I think is going to be a very exciting test for us all to get more involved with. I want to talk about detoxifying mercury. And one of the first comments I want to make is not everybody who has a mouthful of mercury filling should have them removed. You can make some patients much worse, and this is where having a significant degree of discretion is necessary, because you can really tip some people upside down if you try to chelate them. I work in a practice with Dr. Eileen Wright, who's been with me for the last, I think, 11 years. And she and I both come to the conclusion that in treating ALS patients that we just won't chelate an ALS patient, because every single one we've tried to work with, even if we chelate them gently and try to work with them, the increased burden that they have during the exposure time can be profoundly sensitizing to that patient and make them worse. As a matter of fact, one of the worst patients I've ever tried to treat was a dentist, an extremely mercury toxic dentist who's long since retired from his career, but he had significant neurological problems, and no matter how we tried to just the slightest nudge to go after his mercury, we made him much worse. So I want to get the message across that not everybody has a mouthful of fillings should have them taken out. And of course, you want to be very careful about the protection issues. I want to I think I have a moment I can just share a story of a colleague who is a renowned researcher in the field of chronic fatigue syndrome, who decided he had 4 mercury amalgam fillings in his mouth and he wanted to have them removed. And he couldn't find a biological dentist to take them out properly, so he said, well, it's only 4 fillings, how much trouble can that cause me? And he went to a regular dentist who did everything wrong. He pulverized the fillings, no protection, no high volume suction, no separate oxygen for him to breathe. And he sort of turned it into basically into powder, and he ended up breathing in his exposure. Within a couple of months of his removal, he had to quit his practice. Long story short, he developed idiopathic dilated cardiomyopathy, ended up with a heart transplant. So if you think that it's not a significant thing to take the fillings out in the wrong individual, you can ruin your patient's life with it. So just important point to make. Factors that favor detoxification: glycine, potassium citrate. Glycine can act as a courier that can kind of say, this is according to Dr. David Quigg, who actually learned this trick from over a year ago, and it really enhances, pre-treating a patient before chelation with glycine really enhances the yield in a challenge test. Potassium citrate helps to alkalinize the urine and protect the kidneys when toxic metals are coming out. Taking adequate amount of fiber is very necessary and important. And of course, if somebody's constipated, don't try to detoxify them, because they must go out and they must have good bowel function evacuation. And I underline the word patience, because I think this is a race that the tortoise is going to more likely win rather than the hare. Factors that inhibit detoxification are candida and parasites, and there's a lot of speculation about the whole candida parasite piece. I'm sure you've all heard about this. I have not seen anything that really supports the whole concept. I think the first time I heard that, Candida is there as a way, a protective mechanism for the body, is from Dietrich Klinghardt, and he talked about that years ago. And when I queried him about where he came up with that theory, it was basically he'd come across a book on metallurgy that was published by CRC Press, in which they described the process by which they remove mercury from the mine shafts where mercury is being mined, where they would actually take huge vats and inoculate them with candida, water with candida and strep and staph, and they would spray the mine shafts down, and then it would recover the water, and it would have a high yield of mercury. And so he thought, aha, the body is keeping candida and these microorganisms around as a way of trapping mercury and preventing the toxicity, keeping it in the gut. There's no evidence that really supports that, in my opinion. But of course, if a patient has significant candida problems, they've got significant immune impairment, and we know mercury is very definitely related to that. Again, the slow versus fast piece, I like slow, and constipation inhibits detox, and as does impaired renal function. I want to talk about the different agents that we currently have available for detoxifying mercury. And it's a DMSA, which is meso-2,3-dimercaptosuccinic acid. And I want to point out to you the chemical structure of DMSA. Remember, succinic acid is one of the indigenous molecules in our Krebs cycle, and it's necessary for the production of ATP and energy at a cellular level. 4 carbon molecules are in a row, carboxyl group on each end, and 2 sulfhydryl groups in the middle 2 carbons. This is the structure of DMSA. Now, if we look at DMPS, we see 3 carbons in a row. We see, so it's a propanol group, and we see this, the sulfonic group over here, and we see our 2 sulfhydryl groups here. This is DMPS, and I'll be talking about that. Both of these were derived long after the dimercaprol, or British anti-leucite, the structure on the bottom down here. Here we see 3 carbon molecules in a row and the 2 sulfhydryl groups here. And instead of a sulfonic acid group here, we have a hydroxyl group in the end. BAL was developed in World War I by the British. It's called British anti-leucite. Leucite was an arsenical-containing gas that the Germans used to spray in the trenches. And the Brits decided we have to do something to protect these soldiers, so they developed BAL. Well, now BAL is effective in chelating mercury and arsenic, but this problem is it is really stinky, hurts like hell when you get it, and it only comes in an injection. It's an oil-based product, so it was very unpleasant to receive. And so it never really got very popular. DMPS was developed by the Russians, actually synthesized first in 1955, and I'll talk more about that in a bit. But let's talk about DMSA. It's a water-soluble analog of British anti-leucite. Trade names are Succimer, Captomer, and Chemet. Now remember the 4-carbon structure of DMSA. It is, because of its succinic acid base, it's one of these agents that has sort of crossed over between the nutraceutical arena and the pharmacological arena. And so it is sold under the under the name Succimer and Captomer through the nutraceutical end, and then Merck, the drug company, makes Chemet. Stability constants are highest to low are cadmium, lead, iron, mercury, zinc, and nickel. Stability constant is the degree of affinity that a chelating agent has for a specific metal that it's trying to grab. It will prefer to grab these in this order. Now, the order, it's in your handout as well. It's cadmium, cadmium, lead, iron, mercury, zinc, and nickel. Now, this is an important point I want to make on this lecture, if you don't remember anything else, that the stability constant of EDTA, which I'll be talking about, is 10 to the 18th power. The stability constant of, this is with mercury, the stability constant of DMSA and DMPS is 10 to the 36th. The stability constant of mercury with sulfhydryl groups is 10 to the 42nd. So basically, it's like we're trying to steal iron filings from a powerful magnet using a less powerful magnet. We don't have a magnet that is equal to the stability constant and strength of bonding between sulfhydryl groups and mercury. The LD50 of DMSA is 50 times higher than that for DMPS, and it's 4 times more effective than D-penicillamine for increasing urinary excretion. DMSA is most effective in removing organic mercury. And 20 to 25% of the oral dose is absorbed, and the peak blood level occurs in about 30 minutes. 95% that makes it into the bloodstream is albumin bound, and 5% is free fraction, which is able to interact. The biological half-life is only 3 hours, and 70% of an oral dose is eliminated in about 6 hours, so it's quick in, quick out. It is approved by the FDA for treatment of lead toxicity in children. It is most effective at removing mercury from the blood, the liver, the brain, the spleen, the lungs, the large intestine, skeletal muscle, and bone. But I want to talk about the whole blood-brain thing because it's all over the internet that DMSA crosses the blood-brain barrier, and none of the other chelating agents do. There's no evidence that shows that DMSA crosses the blood-brain barrier. And this has been looked at upside one down and one and the other by really very well knowledgeable scientists, and there's just not evidence to show that. Although some animal studies following IV administration of methylmercury, you will find that DMSA is the most efficient chelator for the brain mercury, removing 2/3 of that which is deposited in the brain. Again, you can find different articles that have different opinion about it. Side effects include GI disturbances, urticaria, rash, and mineral depletion. And they talk about the copper, the manganese, molybdenum, zinc, magnesium, cysteine, and glutathione. I have not seen the mineral depletion with DMSA or DMPS, and it's perhaps because I'm not that aggressive in my use of it. Dr. Haley made the point this morning, well, I'll stay here, that the distance between the sulfhydryl groups is not far enough apart on any of these three agents to really wrap around the molecule, because mercury is much bigger than that space affords. And so this is why one of the reasons why he's developed this other new agent that can actually have a broad enough arms and it can swing and it can grab the molecules. But you know, he contends that because of this distance is not enough to really capture it. And you know, remember the word chelate is derived from the Greek term chela, C-H-E-L-E, which refers to the claw of the crab. A true chelating agent, such as EDTA, which is a hexadentate molecule that sort of envelopes and sort of literally like a claw, grabs the toxic metal it's binding and attaches it through 6 different electrical charges. And once it is locked in place, that's it. It's going nowhere except out of the body. These agents can't do that because these are linear complexing agents. And when they grab the toxic metal, they'll escort it down. And one of the contentions that Dr. Haley's made is that it can actually, when it gets to the kidney, it could attach itself to the sulfhydryl groups in the kidney, and it does not necessarily washed out or completed. In reference to that point, one of the observations that I've made is when I start using DMSA or DMPS for chelating patients, the beta-2 microglobulin goes up. Eventually, through time, it will come back down again. But you do see that rise, which I think is additional renal stress. DMSA, in my experience, is really very safe and is generally well tolerated, and it does smell kind of stinky, you know, the sulfur smell. It's best absorbed if you take it away from food. And the dosage protocols are variable. You see them all over the place. You know, you can take them in divided doses, 3 days on, 11 days off. You can do 500 milligrams every other day for a minimum of 5 weeks, or a single dose at night every 3rd to 4th night, or 1 dose a week. I mean, it is as variable as the people that are sitting in front of you. So, you know, it would be good if you could figure out some way of doing autonomic response testing for an individual and try to determine what might be best as a starting point, and then observe how a patient does with it. Any time I'm using any chelating agent, I like to collect urine periodically to see what's coming out as a way of monitoring, in addition to looking at kidney function and liver function with DMSA. But I've never seen a problem with adverse liver problems and anybody with that. Not that it can't happen with more vigorous use. And if I'm using either of these agents, I like to have the patient take a dose of it half an hour to 1 hour before every mercury amalgam removal session. So there is some of this in the bloodstream to help capture any wayward mercury, because I don't care how careful your technique is, you can't sweep the floor without getting dust in the air. The other agent I mentioned is the DMPS, the one in the middle. Remember the 3 carbon molecules, the propane base with 2 sulfhydryl groups stuck up there, and this is the catch for the mercury, is the sulfhydryl groups. It's a water-soluble analog of BAL. Trade names are unithiol, dimovol, and then DMPS hyal. It's most effective in removing inorganic mercury and can be given intravenously, intramuscular, or orally. There are literature reports of its use sub-Q, intraperitoneally, inhalative, and even like periosteal and mandibular injections. I've done quite a bit of neural therapy with DMPS mixed with procaine, and it can have you can see a tremendous increase in yield by doing that technique. DMPS peak blood levels occur in about 3.4 hours. It's more effective than DMSA in removing mercury from the kidneys. One of the key features of DMPS is its absorbability. 50 to 60% of an oral dose will absorb. And if you can take 10 to 30 milligrams per kilogram dose, you can get a much higher blood level by taking it orally than giving it intravenously. The intravenous dose is 3 milligrams per kilogram maximal dose. The doctors in Europe who use DMPS much more readily than we do here think we're nuts in this country for giving DMPS IV. Why should you give it IV? It's much greater potential chance of risk. Well, I have to admit, for years I've given well over 2,000 doses of DMPS IV, and I've seen a half dozen patients who've had problems from either nausea or tachyarrhythmias, which, in every case, once the medicine was gone out of the system, the patient was fine. But there's really not a need to give it IV. 90% of it is loosely bound to plasma proteins versus 95% for DMSA. Remember, 20 to 25% of DMSA will absorb, and so you get much higher levels of DMPS. Stability constant in decreasing order are mercury, silver, methylmercury, copper, cadmium, lead, and zinc. And 90% of DMPS is eliminated through the kidneys, and there's no accumulation with repeated doses. It's really a very low toxicity. You can have a fall in blood pressure following IV dosing. I don't recommend IV dosing. There's no mutagenic or teratogenic effects, and there's no increase in heavy metals in the brain during DMPS therapy. Mercury content in the brain is not affected by DMPS. Again, it is water soluble and does not partition into the blood-brain barrier. Side effects are remarkably innocuous. When I did give it intravenously, I used to notice that at the site of the IV infusion, a patient would often get a rash that would on that very site, and proximally up from that site. And if you pre-treat the patient with intramuscular vitamin B12, we were able to abate that. Allergy, weaknesses, nausea, vertigo, and a list of side effects mentioned. And I've also not seen an adverse effect on essential minerals with the use of this. IV protocols, 3 milligrams per kilogram given as a slow pushover, and in orally you can give 10 to 30 milligrams per kilogram, 50% of which is going to be absorbed. You can give it once a day or in divided doses or 1 or 2 days a week. Again, their protocols for giving DMPS is just as variable are the people who are giving it and those receiving it. I like to monitor effectiveness with urine toxic elements. And there are issues regarding transdermal preparation of the DMPS, and Dr. Buttar spoke here a few years ago about this. I was actually the second doctor in the country that he spoke with about using TD DMPS, and I've had quite a bit of experience with that, and I think that it's slow and plodding and methodical, and I think it's a bit too slow, my own personal opinion about it. Neural therapy applications, I'd like to just tell a brief story if I can. I guess I have time, don't I? About one gentleman that I saw. He was in his mid-30s, and this was years ago, but I'll never forget his case. He was in his mid-30s, and he presented to me with fatigue and brain fog, and I felt that his vision was slipping, and I decided to do. He'd gotten his mercury fillings out, and I said, well, he had a whole mouthful of them prior to seeing me. I said, well, let's just do a DMPS challenge test. I did an IB challenge test, and his urine came back, urine mercury concentration came back at about 40 micrograms per gram of creatinine, a substantial amount. So we've seen much higher. So I started chelating him. I gave him an IV infusion every 2 weeks. And every time I'd give him an infusion, he noticed that his energy level went up, his visual acuity improved, and the fog came away from his brain. And he was really pleased with that, but it didn't last for about a day or two, and he sort of slipped back down again. I went on, and about every 5, 6 IVs, I would collect a urine, and we'd see it go up and go down. And this is one of the points that's worth noting as well when you're doing an IV challenge or an oral challenge, that sometimes you're going to see the levels come down and then they'll go way back up again. And oftentimes the heaviest yield of the toxic metals with mercury will come after they've had 4 or 5 DMPS treatments. And it's like the body was getting rid of some other things in preference to the mercury at the time. But anyway, every time I treated him, he would get better. Then he would retreat again in his symptom improvement. And I did this up until he had 30 treatments and got his mercury urine levels down to about 2 micrograms per gram of creatinine. And then I had just taken Klinghart's course in neurotherapy, and I said, well, I'm going to try something different with him. And I did a 9-to-1 ratio of procaine to DMPS, and I injected his tonsils to get the superior cervical ganglia. And I did segmental therapy over his liver, spleen, and kidneys. And what was left, I gave him IV, so we had the full 3 milligram per kilogram dose, and I had him collect urine. Came back at over 400. And it just absolutely was one of the most telling cases to me that tells me we haven't hit the mother lode. Why these areas, the autonomic nerves, the sensory nerves pick up the DMPS and bring it into the organs underneath it, and the superior cervical ganglia releases this stuff. I have had tremendous yields like this by doing sphenopalatine ganglia injections, cervical or stellate ganglia injections. I don't recommend doing this unless you're really a little nuts like I am, because your patients can stop breathing on you, and that creates angst. And otic ganglia injections. And I have one patient in my practice now that she has persistent tinnitus. And if I do a otic ganglia and a sphenopalatine ganglia injection with her tinnitus goes away for a month every time I do it. But these nerve tissues and these peripheral or accessory brains, as I call them, these collections of ganglia tissues, of nerve tissue, are tremendous pools for mercury. And you just don't just necessarily get at them by going after them systemically. You sometimes need to work at them locally. I like to treat patients half an hour to an hour before each dental or